I have the pleasure today of introducing one of my colleagues, Dr. Snehal Patel, who's going to be speaking to us today. Dr. Patel is Associate Professor of Medicine and the Director of the Cardiac Transplant Program here at Montefiore. He did his training at Boston Medical and then came to New York at St. Vincent's and then did his advanced heart failure training here at Montefiore. And he has risen through the ranks and really become a national and international expert on cardiac transplantation and is well published in driving the field forward to increase the donor pool and allow more people to achieve the benefits of cardiac transplantation, particularly as it comes to hepatitis C infection. And so it is with great pleasure I turn it over to Dr. Patel for his talk today on cardiac transplantation.
Thank you, Dr. Sims, and also would like to thank Drs. Giordi and Dr. Garcia for setting this up and giving me a chance to present today. What I will be discussing is really an overview of cardiac transplantation, and let's start with a little bit of historical perspective and then take you through the process of how we select candidates for transplantation, how the hearts are actually allocated, and what to expect afterwards. And in between, I'm going to touch a little bit upon issues and areas that our group has made, I think, contributions significantly to the field academically as well. So the beginning, and there are certainly a lot of beginnings, but what I think of as the beginning is when the first human heart transplantation was performed. And this was performed by this individual, Dr. Christian Bernard. Many of you may have heard of him already. He performed the first heart transplantation in South Africa. And he transplanted the heart from a 25-year-old female who died in an auto accident into a 55-year-old with end-stage heart failure. That patient died after 18 days from a pneumonia. However, he quickly performed a second transplant and the recipient survived for 19 months. You have to realize that in 1967, there was no PCI. Many of the options for valve replacement, CABG, et cetera, had not been perfected. And there was a thought that maybe heart transplantation was really going to be the therapy for all of these chronic cardiac conditions. However, very soon after, this initial enthusiasm for transplantation had come to almost a screeching halt. So in 1968, the first year in which there was a full year of transplantations, there were 100 transplants done worldwide. And by 1970, it had fell to 18. And the field was really in danger of stopping. And what we realize now is it wasn't about the surgery, it wasn't about the concept, it was always feasible. It was a result of our poor understanding of how to manage these patients postoperatively, in particular, balancing rejection and infection, which we think of as competing risks. So this graph here is a couple of years old, but I think it's really illustrative, and it shows that over time, starting from 1970 up until present, the time to 50% or median survival for heart transplant recipient has increased steadily. What I'll take you through are a couple of the big changes that have happened over time, starting in the 70s when I said survival was measured in weeks. So the first thing that happened around 1974 was a large increase in the donor pool. And this is something I'm going to get back to in a little bit, but the Supreme Court had made a ruling that set forth specific criteria of how you define brain death. So for the first time in this country, people who were brain dead are considered dead. And this gave the perfect opportunity for donors for organ transplantation. And now we went from where each individual case was an ethical and legal conundrum to where we had a group of donors that were readily going to be available. In addition, the donor pool was increased when we realized we could actually cold preserve the donor hearts for a period of time. And quite simply, this meant recovering the heart from the donor and putting it in a bag of ice. And we could transplant it to the recipient's hospital. So no longer did the recipient and donor have to be co-located in the same hospital and adjacent to operating rooms. And in terms of management, the big advancement in the early 1970s was the development of an endomyocardial biopsy technique for diagnosis of rejection, something that we still do today, where we're able to take small pieces of the heart and look under a microscope and see if there's rejection. So rather counting on crude methods with EKG and B mode echo, we could really finally determine rejection, decide when people needed augmentation of their immunosuppression. Probably what's considered the biggest improvement in transplant survival, not just heart, but all of solid organ, is the introduction of cyclosporine. So original immunosuppression regimens consisted primarily of prednisone and azathioprine. And when cyclosporine was incorporated into clinical trials, it was wildly successful. And within a few years was approved by the FDA. And you could see really the steepest improvement in transplant survival happened after the introduction of cyclosporine. And by the 80s and 90s, we're talking about a therapy that could offer up to 9 years of longevity. Other changes that happened was a refinement in the surgical technique. Without going into the details, it changed from something called the biatrial technique to the bicaval technique, where the two cava were anastomosed instead of at the right atrial level. An important thing is that if you think about all of the changes that happened over time, there was only one that was really surgical, and it was this one. Most of the changes happened not in how to do the surgery, but how to manage the patients, select the patients. And I think that's an important thing to understand in how we've gotten to where we are. And finally, in the late 90s, we changed the immunosuppression again to incorporate tacrolimus and mycophenolate based on improved efficacy and a lower side effect profile. So when you put this all together, you come up to current. And this is data from the International Society of Heart and Lung Transplantation, where there's over 130,000 patients. And you can see that the median survival is 11 years. And I look at this and I think it's such a remarkable fact that we take people that have weeks and months to live and offer them a survival of 11. And as you follow this curve out, you can see people living 20, 25 years plus. And there's very few therapies in medicine and cardiology that can offer this kind of benefit. And it's not just mortality benefit, it's also in terms of quality of life. There are a number of different quality of life metrics out there. A really simple one is to ask recipients or patients, do you have any limitations to activity? And so in this study that they did about 10 years ago, but it's still quite relevant, and they asked a cross-sectional cohort of transplant recipients at 1, 3, and 5 years, do you have any activity limitation? More than 90%, as you can see in the red bars, at all time points said they had no activity limitations. So an incredible therapy, not just in mortality and morbidity, and then brings up the question, why aren't all of us as cardiologists, physicians, following hundreds and hundreds of transplant patients? In this question here kind of gets to the answer. So I do not think that I have audience response put on, but just think about this question for a second. How many heart transplants are performed in the US annually? Is it 1,000, 3,000, 10,000, or more than 25,000? And I'll show you the answer here. This is the graph of number of transplants performed in the United States over the last 25 years or so. And you can see that the number hovers right about 2,500. And this is not because we don't have enough people that need transplantation. It's really that we have a limited donor supply. I will point out for interest that about 2010, we started seeing an increase in the number of organ donors. This, amongst other reasons, is primarily driven by the opioid epidemic. So we have seen an unbelievable number of overdose donors, and one of the few silver linings of this terrible opioid pandemic is that there's been an increase in organ donation. So what happens is we really end up with this supply-demand mismatch. We have only 3,000 heart transplants happening per year, but if you look at different estimates, there's over 200,000 people living in this country who could actually benefit from advanced heart failure therapies. And that brings us to this cartoon that you'll see in all heart transplant talks, but I think it's really, really poignant, is that you have a line of individuals who could benefit from heart transplant, but when they go to the heart transplant store, it's closed because the transplants are out of stock. And this leads to two issues. One is that the wait times are really long for transplant. And two, when it comes to allocation, we are stuck in this situation of who gets an organ. And it's not about us deciding who deserves it more, whose life is worth more. The only ethical way we can go about this is that we allocate the organs to patients with the greatest need and those with the greatest chance to derive the maximum benefit. And the best way that I explain this is with an example that happens in our team at least once a year is we'll get a young woman, she had breast cancer, she was treated with adriamycin, now she has end-stage heart failure and could benefit from a heart transplant. Unfortunately, here, just like every other transplant center in the country, we would end up turning her down under the reasoning that the breast cancer is likely to recur and affect her chances for living 5 to 10 years. So if we give her that heart, there's somebody else that's not getting a heart that could live 10, 11 longer years with it. And in order to ensure this happens, CMS doesn't leave it up to the honor system. So they mandate a multidisciplinary heart transplant selection committee. So we meet here at Montefiore every Wednesday morning, and each center across the country, there are about 130 heart transplant centers, have a similar setup. And our committee consists of a cardiologist, surgeons, psychiatrists, our pre and post transplant coordinators, a social worker, a finance person, a nutritionist, a pharmacist, and we've all met the potential candidates. And we sit and we debate, medically, surgically, psychosocially, financially, are these appropriate candidates? And what it does is it takes the power to determine listing away from one person. And this was probably one of my favorite parts of the job, is that we all meet together and really discuss these cases and come to a consensus. Now, just to give you an idea of what are some contraindications for transplant, there are many. Some of the absolute ones I've highlighted in red here. Age, we loosely say 70 to 72 as our upper limit, but certainly we would consider biological age over chronological age. BMI, if you're malnourished with the BMI less than 19, or if you're obese with the BMI greater than 35. Irreversible renal failure in the setting that you're not a candidate for heart and renal transplant. Malignancy, as I discussed, but also other things like a history of non-compliance or inadequate social support. Because the reality is that the mortality and morbidity benefits that come with heart transplantation require an effort on the recipient's part. They have to take medications and they have to be ready for an intense medical follow-up. And if they can't do that, they're jeopardizing a incredible gift. So I'm going to detour a little bit here on something that we have focused quite a bit in our program, and that's how to expand the donor pool, because we see there's not enough donors, and we want to see what can we do as physicians to increase this. Well, there's really two ways to do that. Number one simply is to increase the number of organ donors. Now, we don't directly have as much control over this. This is really about going out and getting people to sign up, public health initiatives. And an interesting concept is to consider a conversion to an opt-out system. And so what do I mean by this? That when you go to the DMV and you take your license, they ask you, do you want to be an organ donor? And you can check yes or no. Well, what if you went there and they said, hey, you're an organ donor, do you not want to be one? And they've done this experiment in Spain where they saw a large increase in the number of organ donors. And I think that that would have a huge impact here. I don't think that our country currently here has the appetite for it, but it is something to think about in the future. Now, besides increasing the number of organ donors, something else to consider is to increase the recovery rate. This isn't discussed as much, but for every 3 hearts that's offered, only 1 is placed. And I will say that many of them are turned down for good reasons. They have cardiac conditions, coronary disease, they died of a cardiac cause, and we're not going to use those for transplantation. But there are still many others that are turned down kind of for soft reasons because we're not sure if it's okay to take these or not. And this is something that we've worked a lot on at our center, and I want to share some of this work. One of the first things that we did was we looked at donor troponin. You can see Dr. Madan here, who is one of our newest faculty, and you'll see his name over and over again in all these papers. We looked at this idea of if somebody dies from brain death and they have a high troponin, but the heart looks normal, could this represent subclinical myocardial dysfunction that could affect the outcome of transplant? So we looked at a large national database of 10,000 individuals. And what we found was that even if the troponin was high, if the heart looked okay, it was still okay to use it for transplantation. And this immediately led to a difference in the way that we accepted organs at our institution. And nationally, when you go around, a lot of people will come up and comment and say that this changed the way that they practice. Something else, also by Dr. Madan and Dr. Yordi, this was published in JACC about a year or two later in 2017. Really, really, really important paper. And the reason behind this is that in brain death, we often see this neurogenic brain cardiac access where there's LV systolic dysfunction after brain death. And that tends to get better over time. But we're not sure, is it safe to use such a heart for transplantation? So what they did was they looked on about 5,000 donors that had 2 echocardiograms during donor management. One with an EF less than 40%, and then the second one that improved to greater than 50%. And they compared these groups and propensity matched people who had an improved EF to those that were considered standard donors. And what they found was that there was no difference in survival up until 5 years. And this is really, really, really impactful work. And probably what I like most from this paper is a central illustration that depicts what happens. So in brain death, you have an initial catecholamine surge causing a sympathetic storm. So you have a loss of sympathetic tone and catecholamine depletion. This leads eventually to a decrease in aortic pressure, coronary perfusion, and global LV systolic dysfunction. Now, if you manage the donor with hormonal, hemodynamic, and catecholamine resuscitation, and you repeat the echo, and the EF improves over here, we can pretty certainly say that the etiology of the LV dysfunction was related to brain death, and that it's okay to take such organs. So this is a really, really neat illustration and something that now has become a standard part of any transplant education. Now, the last thing, as Dr. Sims mentioned, is hepatitis C. This is something that we have really pioneered here. And historically, heart transplant outcomes from recipients of Hep C donors has been poor. So this was an article published in JAMA in 2006. You can see the early and really wide separation of the curves for transplant recipients that got hepatitis C negative versus positive donors. And we know that the reasons are, one, an increase in cardiac allograft vasculopathy, and also early liver dysfunction in the setting of hepatitis C and immunosuppression. So about 5 years ago, there was a lot of momentum to revisit this in organ transplantation for a number of reasons. One was that there's an increase in the number of donors with hepatitis C. So hepatitis C tends to run hand in hand with the opioid epidemic through use of IV needles. Number two, and most importantly, that around 2010, the FDA had approved direct-acting antivirals that essentially cured hepatitis C at a greater than 95% rate. And third was that we developed an on-site test where we can measure PCR, which we call through nucleic acid testing, to see if there was actually viral RNA in the serum of potential donors. And we could separate the donors into those who have hepatitis C with viremia and those that don't. And so one of the first things that we wanted to do when we get into this is something I want to explain. And when we started this, realized I'm not a hepatologist and it's been a while through medical school, so I had to re-educate myself, and I want to show you what our thought process was. So let's say you have an individual who's going to be a potential donor and they're inoculated with hepatitis C. This is time 0. Over the first 8 to 10 days, if you measure their blood for either hepatitis C antibody or through NAT testing for the presence of virus, they're both going to be negative. At about this period of time, they will begin to make virus in their blood. And if you measure the serum, the antibody is going to be negative, but the NAT testing, the virus testing, is going to be positive. Now, as is common in human biology, seroconversion happens at about 2 to 6 months. And now if you test this individual's serum, they're going to be antibody positive and virus positive. 75% of these individuals go on to be chronic disease carriers, and this is their profile. And if they become an organ donor and you use their organs, they will transmit hepatitis C. It's an incredibly infectious disease. A drop of blood, forget about a whole organ, is going to lead to viral transmission. What hasn't been talked about as much is that about a quarter of individuals can spontaneously clear hepatitis C on their own. I don't want to go into why, and I don't think it's completely clear, but if you measure their profile, they're going to have antibody, but they're going to not have any virus in their blood. And hepatitis C, unlike hepatitis B or CMV or other viruses, is not felt to have a latent phase. So once it's gone, it's gone. It's tempting to think that if you transplanted such a recipient, you're not going to transplant hepatitis C. Why is this so important? Well, let me show you how we were using donors just 5 years ago. So this is UNOS data, so national data based on the hepatitis C status of the potential donor. So a donor with no hepatitis C, antibody negative, virus negative, 9,000 plus potential donors, and we accepted 34%. So just like I said before, 1 in 3 acceptance rate. Now, if you look at people that are hepatitis C positive with virus, so a disease carrier, we were barely using these. Like I said, this was considered off limits and dangerous. However, if we looked at people that had the antibody but cleared the virus, we didn't make any distinction. People felt that the risk was the same. So we tested this hypothesis here, and 23 recipients that were followed for almost 2 years after transplantation. We had 2 deaths in this group, unrelated to hepatitis C, but we did not detect virus. So none of these 23 recipients ever developed hepatitis C after transplantation. And the outcomes, at least over 2 years in terms of rejection and cardiac allograft vasculopathy, were similar to other individuals. And this really impacted not only us, but many other centers. And while we were working on this non-viremic donor, there were other centers working on hepatitis C viremic donors, namely the group at Vanderbilt. They published this very similar timing to ours, and they took 13 recipients who had hepatitis C, 13 donors who had hepatitis C and transplanted it and transplanted their hearts. And most of these developed a virus, hepatitis C in their blood, and all were treated with direct-acting antivirals and had a sustained virologic response. They treated these with Harvoni, and the post-transplant outcomes were excellent, with none of the patients dying at close to 1 year follow-up. One of the patients died of a PE, which was felt to be unrelated. So this really ushered in a new era. Dr. Madan, once again with Dr. Yordi, published a larger series follow-up of almost 200 combined viremic and non-viremic donors with 1 year follow-up, and you can see that the survival was similar between hepatitis C and normal donors. And we see the change now based on our work, which is really quite rewarding. As I said, 2015, 2016, these are hepatitis C viremic and non-viremic donors. This is the acceptance rate here, and this is the acceptance rate for a non-hepatitis C donor. Just over 2 years, the acceptance rate has jumped and approached the acceptance rate for non-hepatitis C donors. So something that we really made a big impact on and will continue to do going forward. So getting back to transplant, I mentioned how we go about the selection process. So let's say we have an individual who makes it through the process, is listed for transplant. Well, how do they actually go about getting a transplant? This is where UNOS comes in. So you may have heard this term. It's the United Network for Organ Sharing. They were established in 1977, and they're contracted by CMS to manage all solid organ transplantation in the country. They divide the nation into 11 what they call OPOs, or organ procurement organizations. Our organ procurement organization in this region is called Live On New York. You guys have probably heard that term as well. Here are the 11 UNOS regions. You can see that we're UNOS 9 here in New York State and part of Vermont. Now, what UNOS does is they prioritize the sickest patients first. So they create statuses or tiers of how sick the individuals are. many of you may be familiar with the prior system of UNOS allocation where there was 1A, 1B, and 2. And while this system served us well for 10, 15 years, we realized at about this time it was time to change for a couple of reasons. One is, if you look at the neon green line here, which looks at how many people are active waiting on the wait list, 2016 it was about 1,200. By 2015 it was over 3,000. So the number of people on the wait list had doubled, and what this meant was that the wait times had increased substantially. So if you were the sickest category, 1A, on average, it could take 2.5 months to get a transplant. And this just doesn't make sense that if you're so sick, you're going to die unless you get a transplant in weeks, but you can only wait months to get a transplant. We knew we had to change the system. And this is shown a little bit more clearly here. So you could meet status 1A criteria for a variety of different reasons. So MCSD, which is mechanical circulatory support, or in other words, LVAD. If you had an LVAD thrombus or infection, your mortality on the wait list was very low, 5 deaths per 100 patient years. However, if you were on ECMO or mechanically ventilated, your survival was very poor, 1,500 deaths per 100 patient years. And what this tells us is that the current system, the old system, did not have the discriminatory ability at the sickest, and it didn't allow for urgent transplantation. So what happened was the system was broken into 6 new statuses. Status 1, 2, and 3 largely encompassed the old status 1A. You don't really need to know these, but just to share them with you quickly, status 1A is largely people on ECMO. Status 2 is people on temporary MCS, so balloon pump or refractory VT. Status 3 is people with LVAD complications or sitting in the CCU waiting on inotropes. Status 4 is our stable LVAD and home inotrope patients. Status 5 is dual organs, and status 6 is basically at home with stable heart failure on meds. As I said before, if an organ becomes available, it is offered to the sickest people first. If there's a problem with the match or there's nobody waiting, it gets offered down the line. Really, to be competitive, we feel that you have to be in the status 2 to 3 range. So most of these patients have to be hospitalized to get to goal. So if an organ comes from one of our recipients, how do we decide if it's okay? Well, each donor organ undergoes exhaustive evaluations. We look at graft function, including echocardiography, CAT, the right heart cath, the cause of death, the comorbidities. And if we think it's okay, then we'll match based on, of course, blood type, donor height and weight, how long do we think that the heart will actually be out of the body and not perfuse, which we call the ischemic time, and immunologic concerns. But if all goes well, our recipient has a successful operative course, we start having to deal with the complications that occur afterwards. The early complications are usually RV failure due to somebody who has pulmonary hypertension from longstanding heart failure. We will occasionally see LV failure and sinus node dysfunction, but really what we're focusing on, our primary job is to manage the late complications, to give them this therapy that can last 10, 15, 20 years. And these include the ones you see here, rejection infection, but also renal dysfunction, diabetes, hypertension, hyperlipidemia, osteoporosis. Importantly, these individuals have a malignancy rate that's higher than the general population, and cardiac allograft vasculopathy. When you look at all of these, the interesting thing is outside of rejection, we feel that many of these complications are due to immunosuppression. So the therapy that we give them to prevent rejection causes all these other problems. And we think of this as really a long-term trade-off of trading the disease of heart failure for that of immunosuppression. However, when it's done right, we can actually manage this quite well to offer that great mortality and quality of life benefit. But it's really important for the patients to understand that this isn't like, give me a new heart and I'm all set. Actually, the number of medications and the intensity of follow-up is going to be much longer and much more intense than it was beforehand. So this is just a sample medication list of what somebody will go home on after heart transplantation. Now, probably the biggest burden outside of the medications for the patients is biopsies. So we have to pick up rejection before it is clinically obvious. And we do this with biopsies. So we will access the right internal jugular vein and under echo or fluoroscopy snake a bioptone and take small pieces of the RV septum and look at them under the microscope. And what we're mostly looking for is cellular rejection. It's mediated by the T cells. Now, rejection doesn't mean the heart is completely lost, and that's why we pick it up early. About 25 to 30% of individuals after heart transplant will have some degree of cellular rejection in the first year. And we know that the risk of rejection decreases over time. There is this process of immunologic tolerance that occurs. So we will do 14 biopsies in the first year, and they're spaced out starting weekly to biweekly to monthly. If we do pick up rejection, well, our therapy is pretty straightforward. It's we want to kill the T cells. And we'll do this either with steroid pulse, augmenting their maintenance immunosuppressant regimen, or in severe cases, even using cytolytic therapy that wipes out all their T cells. This is how we grade rejection. 0R is none, all the way up to 3R, which is severe. And basically on the biopsy, we're looking for two simple things: number of T cells and whether there's myocyte damage. And based on that combination, we have a grading system and we decide how to treat them. So I wanted to switch gears here for the last 10 minutes or so and talk about some of the innovative things that we're doing in cardiac transplantation here in Montefiore, really to stay on the cutting edge and help push the field forward. One of the things was something I just mentioned. Here's a first-year biopsy schedule for one of our patients that's about to be discharged, that just got transplanted. There's just 14 biopsies in the first year. So this is a huge burden. It's painful, it's uncomfortable, and reduces the patient's quality of life. Excuse me. So there's really a big stimulus, and we've been looking for a way to find non-invasive screening for rejection. And something that we're taking in right now that I'm really excited about is this idea of donor-derived cell-free DNA. So what happens pre-transplant is we know the donor and we genotype their DNA, and we know the recipient and we genotype their DNA. The individual undergoes a heart transplant. Here's the donor heart in green. And after transplant, if we take their plasma and look for DNA that's broken free of the cell, we should see mostly recipient DNA with an occasional donor DNA that's coming from the heart. And the data has shown that cell-free DNA of the donor after the first couple of days decreases really, really quickly to less than 1% of the donor fraction. However, when there's rejection, there's myocyte injury and there's more DNA released. And what we can see is that the donor fraction at the times of rejection jumps dramatically. It can be up to 5% or such. And so we are partaking in a multicenter study with about 20 other centers in the country in the Surveillance Heart Care Outcomes Registry. And what we're doing is we're looking to enroll almost 1,600 subjects and compare their outcomes looking at just the cell-free DNA versus rejection. And this is something that I think in 10 years from now, we will rarely be doing biopsies, and really is going to change the quality of life and the way that we approach transplantation follow-up. The other thing that we're doing that is pushing boundaries is expanding the donor pool through DCD. So what does DCD stand for? This is donation after circulatory death. And remember, I said that most of the donors in this country come after a donor is considered brain dead, so they meet the legal definition of brain dead. However, the majority of individuals in this country don't die from brain death, they die from other causes. And this is an opportunity for organ donation from patients whom death is declared because circulation has ceased. So what happens, you may have somebody in the ICU that's very ill and themselves or their family have decided that they want to withdraw care. Care is withdrawn. Circulation completely ceases, the heart stops, and there's declaration of death. And we have to wait at least 5 minutes to say that this individual is dead. And then the organs can be recovered. Now, since the heart is stopped, we have to reevaluate it. And we do it by placing it on this TransMedics organ care system where we can measure both the function and some of the metabolic profiles of the heart and decide whether it is appropriate and move forward with transplantation. So we are about hopefully ready in the next couple of weeks to do the first transplantation from a DC donor in New York using the Transmedics system. And the last thing I'm going to mention is about transplant longevity. This is one of the hard things that we do is that we're talking about a therapy that we institute now that can affect them 10, 15 years later. But it is important for us to think about that, because if you take, younger recipients, 20, 30, 40, 50-year-olds, 15 years doesn't give them a normal life expectancy. So we haven't really cured them. And if we look at what are the leading causes of death as individuals get further and further away from transplant, you'll see it's primarily driven by the green line, which is graft failure. Also, another common cause is CAV, the red line here. And both of these are felt to be mediated by inflammatory and immune responses that occur early after transplantation. What I mean is that at the time of transplantation, there's ischemia, reperfusion injury, all the immunologic responses. What we do right now is we don't really focus on everything. We focus on one thing, and that's to target the T cell response. All of our immune suppression is designed to specifically target the T cell response. However, there are a number of new agents out there that work more broadly. One of them is tocilizumab. It's an antibody, a monoclonal antibody to the IL-6 receptor. It goes by the brand name Acmera. It's approved for rheumatoid arthritis, and many of us have probably heard about it, to treat COVID post-inflammatory syndrome. So we're one of 16 sites in the National Institute of Health study, and we're just about to begin enrolling in this study, and I'm actually really excited and think that this might make a big difference down the road. So let me just finish by showing you historically how our program has done. The current iteration was formed in 2005. We started out doing a few transplants, and over the last year, we do on average about 40 transplants. Last year was a COVID year. We were essentially shut down for 3 months. But we're back on pace to do 40 to 50 transplants. And it may not seem like a lot, but if you look at international data globally, how many transplants does each program do? You see that most programs do about 10 to 19 transplants. And the number of programs that are doing 40 plus transplants is very few, and that's one of us. That's what we're one of. And I think we're all very proud to be working at a large volume program that has excellent outcomes. So I'm going to stop there and conclude by saying that heart transplantation has made significant progress over 50 years and now offers a median survival of greater than 11 years. Unfortunately, donor availability limits this therapy to a fraction of the patients in need. And the future really needs to focus on increasing organ donors and donor acceptance rate. And I think a team-based approach to cardiac transplantation really fosters success. As I say, team, this is our team. It's amazing how much effort and how many people it takes to really make this work. And you can see us all here. So with that, I'm happy to take any questions and hand it over to Dr. Sims.
Yeah, so Snehal, thank you. That was fantastic. A really, wonderful going over the literature and the history and what we do here. Happy to have people put questions in the chat. We'll be happy to get to them. One question I have that struck me, is we used to think about heart transplant, someone with heart failure, a dilated cardiomyopathy who, has no comorbidities and they've just got terrible, terrible heart failure, and they were, the ideal person to transplant. But we don't really see that so much anymore. And I know I talked with referrings who will say, well, I don't know, is this someone you guys might like to transplant or not? So when should patients be sent that we need to be thinking about heart transplant and make their way over to see you or any of us here in the Heart Failure Heart Transplant Center?
Yeah, I think that's a really good question, and maybe is even a talk in its own about who should be referred for heart transplant. And I think we know that, we want to get the patients in the right window. When they're sick and shock and multi-system organ failure, it's too late. At the same time, as you've pointed out, the therapies that we have for heart failure patients is so good right now. We don't want to offer transplant to somebody that is at least getting by on maximal heart failure therapy. So we're trying to find that perfect window in the middle. It's probably actually the part of our job that requires more art than science. But there are definitely some factors we look at. So people that are getting readmitted despite being on good medical therapy, people that have escalating doses of diuretics, people that have recurrent readmissions. We'll also look at functional performance. So we know that exercise testing, especially CPET, can help prognosticate better than almost anything else we have in objective form. And I am always of a big proponent, I think you and all of us are, at least if you have a patient that doesn't look 100% rock stable in New York Heart Association 1, it's not unreasonable for them to come over and see us and just meet the team with the idea that maybe at some point in the future they're going to need something.
Very, very useful because I agree with you. You know, we can't miss that window, and better early than late. And, you know, meet the team and maybe be seen once a year, every 6 months, and you know, work out any potential modifiable barriers to transplantation. Looks like we have a question here from Dr. Zhang. Does cardiac imaging play a role in detecting transplant rejection?
Yeah, excellent question. I think that when we look at really just crude EF as a marker of rejection, we've probably gotten to it too late. We want to pick it up before then. There's certainly a number of people that have looked at MRI, and while there may be some benefit to that, you know, MRI, I'm not sure how much more practical it is than biopsies, and, you know, sending somebody for 14 to 15 MRIs in the first year. One thing I think that, you know, we've even spoken, Dr. Zhang, about collaborating on is strain imaging. So can we pick up subclinical systolic dysfunction? And I think that definitely may be a possibility in the future. It just, I think, requires a little bit more refinement in the technique.
Okay. And you know, one other thing I was wondering about, you know, it really talked about how we can expand the donor pool with all these different ideas. What do you think? You know, is there an upward limit of what percentage of patients we will be able to accept? You know, you said about, you know, 30% currently, and it looks like with hepatitis, we're inching up, you know, about 25%, getting towards that 30% range. But as you mentioned, you know, a lot of these donors are older and died of a cardiac cause, which we'd never take. What do you foresee as something reasonable where we might be able to achieve to increase the number of donors?
Yeah, I mean, it's really tough to estimate that. I think in the current environment where we offer a therapy and we say, here, you know, you have a 90+% chance of living 1 year and 50% chance of living 13 years. If we're going to be really selective about that, maybe 40–45%. But if we start looking at people that have really bad hearts and say that it's okay to take older donors, with the idea that maybe you're not going to live 13 years with a transplanted heart, may actually change our acceptance quite a bit.
A question here from Dr. Bradlow. Has there been any thought to why hearts get arteriopathy after transplantation when kidneys seem to be relatively spared from this complication?
Excellent question. I do not know about the parallels to kidney, although I thought they do develop an arteriopathy as well. It just doesn't become as significant in affecting dysfunction. I mean, we certainly think it's an immunologic response. The exact pathophysiology about it, we haven't figured out. It's definitely multifactorial, both in donor factors and recipient factors, and how we manage them. But you know, solving that problem is going to be one of the big things at increasing this longevity even further.
Well, that's it as far as I see here in the chat box for questions. I think we'll probably stop here, but I just want to again say thank you to Dr. Patel for speaking today, and for all those who tuned in here to Monty Hart on YouTube. And we thank everyone for their participation, and again, especially to Dr. Patel for this really insightful talk.